الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Human Papilloma Viruses HPV by Professor Mahmoud Hani Sulaiman. At the beginning, I would like to say the importance of these viruses that they can lead to many cancers and warts, and all this can be prevented by preventive measures, mainly vaccines. Etiology. HPVs are small, non-enveloped, double-stranded DNA viruses of papillomaviridae family grouped based on DNA sequence variation. Different types have different tissue tropism. Types 6 and 11 lead to condylomata acuminata. Condylomata acuminata leads also to recurrent respiratory papillomatosis. Conjunctival papillomas rarely are found in cancer. They are called low-risk types. Theory continued. High-risk types, which are types 16, 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, 59, 66, and 68, included in HPV clinical tests. They are either low-grade cervical cell lead to low-grade cervical cell abnormalities, or high-grade cervical cell abnormalities. That is to say, they are precursors to cancer and anogenital cancers. High-risk HPV types detected in 99% of cervical precancers and 90% of invasive cervical cancer. Etiology continued. About 50% of cervical cancers worldwide are due to Hpv type 16 and 70% due types 16 and 18. So you can say 50% are due to type 16 and 20% are due to 18. Collectively, they can lead to 70% of cervical cancers. Majority of other HPV-related cancers, anogenital cancers at valvular, vaginal, penile, anal, and oropharyngeal cancers, HPV 16. Risk of cancer, precursors, or cancers is increased in people with immunocompromised, especially who did transplant or with HIV, suggesting that alterations in T lymphocyte immunity may impair clearance of infection. Epidemiology of HPV. Virtually all adults infected with some type of HPV during their lives. For example, in US, HPV infection is 79 million and annual incidence is 14 million infections. HPV types involved in common hand and foot warts are quite different from mucosal types. Non-genital hand and foot warts occur commonly among school-aged children, in whom prevalence equals 50%. Transmission by casual contact facilitated by minor skin trauma. Autoinoculation will lead to spread of lesions. Epidemiology continued. Genital HPV transmitted primarily by skin-to-skin contact through sexual intercourse and other close genital tract. Genital contact. In US, for example, women highest prevalence in 20 to 24 years of age, mostly subclinical and clear spontaneously in 2 years. Cancer is uncommon outcome of infection, requires decades of persistent infection with high-risk Hpv types. Hpv is cause of most vulvar, vaginal, penile, and anal cancer, as well as 70% of oropharyngeal cancers. Rarely, Hpv infection transmitted to child through birth canal during delivery or from non-genital sites. When anogenital warts identified in a child, sexual abuse must be considered while noting possibility of vertical transmission to neonates. The incubation period for symptoms of Hpv infection is estimated from 3 months to several years. 3 months to several years. Clinical manifestations. Most Hpv is subclinical and 90% resolve spontaneously in 2 years. However, persistent Hpv infection can lead to benign epithelial proliferation, warts of skin and mucous membranes, and cancers of lower anogenital tract and head and neck. Hpv is grouped into cutaneous and mucosal types. Cutaneous types will cause common skin warts, plantar warts, flat warts, and thread-like filiform warts. Cutaneous warts are benign. Clinical manifestations continued. Low-risk mucosal types associated with warts of mucous membranes, including upper respiratory tract and anogenital, oral, nasal, and conjunctival areas. Other high-risk mucosal types associated with precancers, cancers including cervical, anogenital, oropharyngeal cancers. Common skin warts are dome-shaped with conical projections, giving surface rough appearance. Skin warts are painless and multiple, commonly on hands and around or under nails. When small dermal vessels become thrombosed, black dots appear in warts. Plantar warts on foot, often larger than warts at other sites, and may not project through much of the skin surface. They can be painful when walking and characterized by marked hyperkeratosis, sometimes with black dots. Flat warts commonly face and extremities of children and adolescents. Flat warts, usually small, multiple, and flat-topped, seldom exhibit papillomatosis and rarely cause pain. Filiform warts occur on face and neck. Anogenital warts, also called condylomata acuminata, are skin-colored warts with papular, flat or cauliflower-like surface that range in size from few millimeters to several centimeters. These warts often occur in groups. In males, found on penis, scrotum, anal or perianal area. In females, these lesions on valvular, anal, or perianal areas, and less commonly in vagina or on cervix. Warts usually are painless, although they may cause itching, burning, local pain, or bleeding. Invasive cancers due to Hpv include cervix, vagina, vulva, penis and anus, and oropharynx. Cervical cancer, most common due to HPV in females, and oropharyngeal cancer, most common due to HPV in males. Anogenital low-grade squamous intraepithelial lesions, LSI-LS, due to persistent infection with low-risk or high-risk HPV types, whereas high-grade squamous intraepithelial lesions, HSI-LS, due to persistent infection with high-risk HPV types. In cervix, HSIL, due to presence of cervical intraepithelial neoplasia, CIN, grade 2 or 3, which are precancerous lesions. These lesions detected by routine screening with cytology, Pap test, and or clinical HPV test. Tissue biopsy is required to make diagnosis. Endocervical glandular precancer adenocarcinoma in situ, AIS, also due to persistent infection with high-risk HPV types. Recurrent respiratory papillomatosis is a rare condition with recurring papillomas in larynx or other areas of upper respiratory tract. Called juvenile onset when less than 18 years, adult onset can occur. Juvenile onset type due to vertical transmission of HPV type 6 or 11 from mother to her infant at time of delivery. Undiagnosed, most commonly in child between 2 to 5 years with clinical voice change, e.g. hoarseness. Diagnostic tests. Most cutaneous and anogenital warts diagnosed by clinical inspection. Routine cervical cancer screening guidelines direct interval at which Pap test performed, when HPV clinical tests added, and when colposcopic evaluation with biopsy should be performed. Valvular, vaginal, penile, and anal lesions diagnosed by visual inspection, even with magnification. Sometimes cytology used and biopsy, but there is no routine screening recommended for cancers at these sites. For all anogenital lesions, diagnosis made on basis of histologic findings. Respiratory papillomatosis diagnosed by endoscopy and biopsy. Diagnostic test continued. Detection of HPV infection by detection of viral nucleic acid, DNA or RNA. Clinical tests for high-risk HPV types may be used in combination with Pap testing for cervical cancer, screening in women 30 years or older, and for triage of equivocal Pap test abnormalities in women 21 years or older. Continued diagnostic test. Number of HPV DNA or messenger RNA detection and genotyping assays found. Liquid-based cytology collection and transport kits permit performance of Pap smear cytology and HPV detection and genotyping on same specimen. There are differences in appropriate clinical application for each, whether used as initial alone test or in secondary screening algorithm. None recommended for use in females less than 20 years or for males. Treatment of HPV. There is no treatment for HPV infection. Treatment directed to lesions due to HPV. Regression of non-genital and genital warts occur in about 30% of cases in 6 months. Most methods of treatment of cutaneous warts use chemical or physical destruction of infected epithelium, including cryotherapy with liquid nitrogen, laser or surgical removal of warts, application of salicylic acid products, or application of topical immune modulating agent. Daily treatment with tretinoin is useful for widespread flat warts in children. Treatments for genital warts are either patient-applied or provider-done. Interventions include ablational and excisional treatments or topical anti-proliferative or immune-modulating medications. Oral warts removed by cryotherapy, electrocautery, or surgical excision. Recurrences are common and may be due to reactivation rather than reinfection. Cancer precursor lesions in cervix or elsewhere in genital tract may require excision or destruction. Treatment of cervical lesions can cause substantial economic, emotional, and reproductive adverse effects, including higher risk of preterm birth. Management of invasive cervical and other anogenital and oropharyngeal cancers requires a specialist. These are some pictures for these warts. This is digitated human papillomavirus warts with finger-like projections on a child index finger. This is human papillomavirus warts on the foot of an immunocompromised 14-year-old boy. This is laryngeal papilloma, may cause hoarseness, although rare they can occur in infants of mothers infected with human papilloma virus. A 13-month-old girl with condyloma acuminata around the anus from sexual abuse, sodomy. This is patient with condylomata acuminata presented with soft wart-like growths on penis. 12-hour post-podophyllin treatment. Condylomata acuminata equal epidermal manifestation due to epidermotropic human papillomavirus, most commonly in penis, vulva, vagina, cervix, perineum, and perianal area. Prevention of HPV. Recently developed HPV vaccines dramatically decrease rates of infection and disease due to HPV types of vaccines. These vaccines are against virus types causing anogenital tract disease. To date, two vaccines. The first is a quadrivalent product, Gardasil of Merck Company, containing HPV types 6, 1, 16, and 18, and one bivalent vaccine, Cervarix by GlaxoSmithKline, containing types 16 and 18. So the first one, besides 16 and 18, contains 6 and 11. HPV types 6 and 11 cause 90% of anogenital warts, whereas types 16 and 18 responsible for 70% of cervical cancers. Both vaccines highly immunogenic as measured by serum antibody titers after vaccination. People who are at baseline not infected with a specific virus type contained in vaccine and who adhere to study protocol rates of vaccine efficacy exceeded more than 90% as measured by both infection and disease due to that specific virus types. Study participants who are infected at baseline with a specific virus type in vaccine do not benefit from vaccine against that type, but may benefit from vaccine against other virus types contained in vaccine. Thus, available HPV vaccine have potent prophylactic effects but not therapeutic effect. The Committee for Vaccination recommends HPV vaccine routinely offered to girls and young women 9 to 26 years. Girls and young women 9 to 26 years. The quadrivalent vaccine also licensed for use in males. The committee stated vaccine used to prevent anogenital warts in boys and young men, also 9 years to 26 years, because 1/3 of cervical cancers caused by HPV types not contained in vaccine. No changes in cervical cancer screening programs are currently recommended. Barrier methods of contraception also helpful in preventing transmission of condyloma acuminata and other anogenital HPV associated disease. Methods to prevent HPV infections are limited to avoidance of contact with infectious lesions. Ideally, vaccine should be administered before potential exposure to HPV through sexual activity. However, females who are sexually active should still be vaccinated consistent with age-based recommendations. Sexually active females who have not any of 4 HPV vaccine types 6, 11, 16, and 18, all of which Hpv prevents, or any of 2 HPV vaccine types 16 and 18 receive the full benefit of vaccination. So sexually active females receive the full benefit of vaccination. Hpv vaccine 4 or vaccine 2 can be given to persons with history of genital warts, abnormal Papa test, or positive HPV DNA test, because these conditions are not evidence of previous infection with all HPV vaccine types.